2:40 in the afternoon, today afternoon. Yes. Okay, so I will write a message.
Wait, doctor. What? At 2:40 we'll start another lecture?
Yes, please, I wrote.
But you said it will be the last lecture.
No, this is not the last. I just now recalled that there will be.
And for the course, it will be the last lecture today at 2:40?
Yes, 2:40.
أكيد صحة وهنا على رجلي حيل.
Sorry.
دكتور, it's $2 you wrote.
أنا ذال.
صح شباب.
خليها تبلش.
أنا دول هذا عمد يحكي معي.
دكتور when you start.
ولك شو يا غالي؟
Okay, so can we start now?
كيف حالك حبيبي؟
Hello students, turn off microphone. Please start.
Turn off microphone please. والله منيح. أنا كيف حالك أنت حبيبي؟
كيف باس.
Okay, so
To close the phone. Okay, doctor. Turn on the phone.
please, so let's discuss about diabetes and who wants
diabetes آخرات.
أبو نضال كيف حالك؟
I will accept all students who want to listen to the lecture, okay? But silence to hear when somebody want to enter the lecture, okay? Okay, so let's start. So today's presentation will be on diabetes mellitus in children. We'll discuss about the etiology, pathogenesis of diabetes type 1 and type 2. It is a very common chronic metabolic disease characterized by hyperglycemia, that is the most important and the most specific biochemical feature. A major form of diabetes are differentiated by insulin deficiency or insulin resistance. So type 1 diabetes mellitus result from deficiency of insulin secretion because of pancreatic cells damage. Type 2 diabetes is a consequence of insulin resistance that occurs at the level of skeletal muscle, liver, adipose tissue, and different degree of beta cell damage. So type 1 diabetes is the most common endocrine metabolic disorder of childhood and adolescence. And it's very important because the treatment is lifelong, and on the treatment and in time, students, please silence. On the treatment and in time diagnosis depend the quality of life of these patients. And quality of life depend on the emotional, psychological condition of the patient because it's a lifelong, it's a chronic disorder. So patients with type 1 diabetes, they have a serious lifestyle changes. They have to do injections of insulin. They have to change their diet. They have to adapt their lifestyle. So that's why it's not easy for them. And also they need to monitor the level of the blood glucose or blood sugar, sometimes daily. They have to be careful. And they need to pay attention to the diet. So just to be clear for you, I'll just interrupt for a second to accept other student to enter the lecture. Okay. And we continue. So morbidity and mortality is depend on the metabolic derangements and on the complications. Of course, patients who respect the treatment and the diet, they will have less complications and later development of these complications. That's why, of course, the morbidity and mortality will be lower. But for patients who do not respect this, of course, mortality will be and morbidity will be higher, will affect them mostly. And the most important complications we'll discuss in details later, but these affections of small and large blood vessels, retinopathy, nephropathy, neuropathy, ischemic heart disease developed already in adulthood, and arterial obstructions with gangrene of extremities. So acute clinical manifestations are caused by hypoinsulinemic and hyperglycemic ketoacidosis. The genesis of type 1 diabetes is autoimmune, and long-term complications are related to hyperglycemia. So diabetes mellitus is not a single entity, but it's a heterogeneous group of disorders in which there are distinct genetic patterns, as well as other etiological and pathophysiological mechanisms. And you will see in the next slides classification of diabetes and other categories of glucose intolerance. So in this slide, you see the etiologic classifications of diabetes mellitus, and you see that there are about 10 groups of etiological types of diabetes mellitus or causes, etiology, 10 groups of causes that lead finally to hyperglycemia. You see through this process, you may see type 1 diabetes caused by beta cell destruction, immune-mediated or idiopathic, that means without evident cause. Type 2 diabetes caused by insulin resistance and insulin deficiency, but also the genetic defects of beta cell function. And these genetic defects include a group of diabetes. Yes, students, please turn off microphones. Genetic disorders of beta cell function include diabetes of the young, the maturity onset, so-called MODY. MODY syndromes, they are called by genetic mutations in chromosome 27, 12, and 17. And also there are mitochondrial DNA mutations that can lead, included in some syndromes that can lead to diabetes. Another group of etiology of causes of diabetes is drug or chemically induced diabetes. What this means? Patients that receive, that are administered cyclosporin, and these are patients with, can be with chronic kidney disease, with renal nephrotic syndrome, end-stage renal disease, with blood diseases, aplastic anemia, for example, or patients with other autoimmune disorders. They receive cyclosporin and they may develop diabetes as a consequence, or patients who receive L-asparaginase or beta-adrenergic blockers, phenytoin, that means patients with epilepsy, patients that receive alpha interferon for hepatitis. So there are a lot of drugs that can lead to diabetes. Also, another group, these are diseases of exocrine pancreas, and you know that cystic fibrosis is associated with diabetes that develops in later stages in adolescents and adolescent children. Or, for example, diabetes can develop after trauma if pancreas was affected, or after pancreatitis. Infections, let's not forget about infections that can lead to diabetes, and especially this include congenital rubella infection. And you remember about this virus that is for children, in fact, is not so dangerous. But if a pregnant woman develop acute rubella, this can lead to anomalies of fetal development or to lesions of pancreas, and the child later will develop diabetes. Or cytomegalovirus, also congenital infection, but is acquired hemolytic uremic syndrome. You know, this syndrome is caused by toxigenic type of Escherichia coli. Another group of etiology, these are causes or etiology of type 2 diabetes in different genetic defects of insulin action or acquired defects of insulin action, but also pheochromocytoma, Cushing, and another group, these are genetic syndromes with diabetes and insulin resistance or deficiency, for example, Prader-Willi or Prune-Bailey syndrome, Down syndrome, Turner, Klinefelter. Also another etiology is gestational diabetes. What this means, this is diabetes in the pregnant woman, and it is correlated with later development of diabetes in the child born from a woman who developed diabetes during pregnancy. But let's not forget about other disorders in childhood, like celiac disease. And also there is one more group of etiology, neonatal diabetes, that can be transient or permanent and also related to some genetic metabolic disorders. So as you see, type 1 diabetes mellitus generally has a lot of causes. That's why we see the high number of patients all over the world. So we'll discuss mostly about type 1 diabetes that has more impact on the lifestyle and need more treatment and is more associated with high risks. So type 1 diabetes is formally called insulin-dependent diabetes mellitus or juvenile diabetes because it is characterized by a low level or absence of endogenous secreted insulin. And it is associated with so severe complications such as ketoacidosis, that is the acute life-threatening complication. So evolution of type 1 diabetes mellitus has 4 stages. First is preclinical beta cell autoimmunity with progressive defect of insulin secretion. Second is onset of clinical diabetes. Then is next stage is transient remission or so-called honeymoon period. And finally is established diabetes when acute or chronic complications develop and decrease life expectancy. So the incidence of diabetes by geographical regions, you see, is very high and it's increasing from the last century, and it's still increasing and continue to increase. And the onset occurs predominantly in childhood. Median age is from 7 to 15 years, but may present at any age. The incidence, you see, is increasing in all parts of the world. And it's characterized by autoimmune destruction of pancreatic islet beta cells. The pathogenesis include genetic susceptibility and environmental factors that contribute to the pathogenesis. Susceptibility to type 1 diabetes is genetically controlled by alleles of the major histocompatibility complex class 2 genes expressing human leukocyte antigens. Autoantibodies to beta cells antigen, such as islet cell cytoplasm, insulin autoantibodies, antibodies to glutamic acid decarboxylase, and other are detected in serum of these patients. And these antibodies, interestingly, they can be detected years or months before the clinical onset of the disease. So type 1 diabetes is associated with autoimmune diseases such as thyroiditis, celiac disease, and Addison disease. Somebody connected, okay. Addison disease. In some children and adolescents with apparent type 1 diabetes mellitus, beta cell destruction is not immune mediated. So this subtype of diabetes occurs in patients with African or Asian origin and is distinct from known causes of beta cell destruction, such as drugs, chemicals, viruses, and other etiology. They may have ketoacidosis, but they have extensive periods of remission with variable insulin deficiency that is more similar to type 2 diabetes. So children and adolescents with this type of diabetes, type 2 diabetes, are usually obese. So this is different from type 1 diabetes. Excuse me, just 1 second. 1 second. Да. Okay, excuse me, it was an emergent call. So children and adolescents with type 2 diabetes that is different from type 1 diabetes, first of all, manifest obesity. But this is not insulin dependent, and these patients, and they're not insulin dependent, and they quite rarely develop ketoacidosis. So patients with type 2 diabetes, they may develop ketoacidosis in some severe infections or after stress or in some other stressful or demanding environment, and they may need insulin just to correct the hyperglycemia, but later on it's maybe not necessary. So they are not dependent on exogenous insulin. So in type 2 diabetes mellitus, we have mostly diabetes that are seen in adults that is characterized by insulin resistance and progressive defect of insulin secretion. Because type 2 diabetes mostly onset is in adolescent period. So this type of diabetes formerly was known as adult onset diabetes mellitus or non-insulin dependent diabetes mellitus. It has a more insidious onset, and polyuria and polydipsia is not always the most specific clinical signs in these patients. And in contrast to patients type 1 diabetes, who are diagnosed when clinical picture develops, children type 2 diabetes, they may have a more prolonged period of diagnostic process with because mostly they have excessive weight gain, fatigue, and it may take sometimes months to be diagnosed with type 2 diabetes. That's why there are screening for children with obesity. There is all the time we screen for glucose level in order to establish in time the diagnosis. So incidence of type 2 diabetes in children increased more than tenfold since the last century, and you see prognosis show that it will continue to increase, and this is correlated with childhood obesity that also increase. One of the characteristic manifestation of type 2 diabetes is acanthosis nigricans. Nigricans, that is a dark pigmentation of skin, creases in the nape of the neck especially. That is a sign of insulin resistance. It is accompanied by relative hyperinsulinemia when it is diagnosed. But serum insulin levels is disproportionate, and it more suggests an insulin insufficiency. So I was mentioned, one was the slide with classification of etiology. I mentioned maturity onset diabetes of the young, MED, and in some children with a strong family history of diabetes, the impaired glucose tolerance may occur in a pattern implying dominant inheritance. So what this means? It means that MED is a type of diabetes that has a genetic background, strongly genetic background, manifested clinically with impaired glucose tolerance. It may require insulin treatment and can be treated with sulfonylurea with varying degree of success, and often is now referred to as monogenic diabetes. So it's a genetic type of diabetes. So patients that have MODY present with hyperglycemia. They also clinically manifest polyuria, polydipsia, and can be diagnosed by screening. There is no, in this type of diabetes, in MODY, it is genetically, and it is proved also by the fact that there is no autoimmune destruction of beta cells and no HLA association. So MODY, in fact, is a result of specific genetic disorders involving mutations in the gene encoding pancreatic beta cells and liver glucokinase or nuclear transcription factor, hepatocyte nuclear factor. So also, a defect in the gene regulating transport into the pancreatic beta cells also can be responsible for other forms of type 2 diabetes. So, in fact, genetic basis of type 2 diabetes include defects in glycogen synthase, insulin receptors, and other signaling molecules. What other specific types of secondary diabetes are known today? It includes diabetes secondary to exocrine pancreatic diseases such as cystic fibrosis, other endocrine diseases like Cushing's syndrome, and as a consequence of some drugs or poisons. For example, in organ transplantation survivals, I was mentioning about cyclosporin. I forget to mention that cyclosporin is also used for immunosuppressive regimen in transplantation, and this drug is largely used. So in these transplanted patients is used cyclosporin, tacrolimus, and it was seen that these patients are at high risk to develop post-transplantational diabetes mellitus. So there are also certain genetic syndromes that are associated with some insulin receptor anomalies. Autoimmune destroy of beta cell. What means impaired glucose tolerance? So the term impaired glucose tolerance, in fact, refers to a metabolic stage that is intermediate between normal glucose homeostasis and diabetes. So the upper limit of normal fasting glucose concentration is 5.5 millimoles per liter or 99 milligrams per deciliter. This choice of this normal range is the level above which acute phase insulin secretion is lost in response to intravenous administration of glucose and is associated with progressively greater risk of development of micro and macrovascular complications. So many individuals with impaired glucose tolerance, that means that fasting glucose is higher than 100 milligrams per deciliter, are euglycemic in their daily lives and may have normal or nearly normal glycated hemoglobin levels. So these individuals with impaired glucose tolerance often manifest hyperglycemia only when they're challenged with oral glucose load. So with this test. So what probably from endocrinology, that you study diabetes mellitus probably in endocrinology and internal medicine, you know about oral glucose tolerance test. So the patient is given concentrated solution of glucose and is measured the fasting glucose level and measured then the glucose level after 1-2 hours after this ingestion of this solution. And the patients with impaired glucose, individuals with impaired glucose tolerance, they may have hyperglycemia only when this test is performed, but daily they may have normal glucose in the blood. So if the individual is not pregnant, the female is not pregnant, the impaired glucose tolerance is not a clinical entity, so it's not a disease, but in fact it's a risk factor for further diabetes and cardiovascular disorders. And insulin resistance, you remember that is primarily involved in type 2 diabetes mellitus, because type 1 we have insulin deficiency. So impaired glucose tolerance test is a marker of the risk for type 2 diabetes, because it showed that this insulin is resistant. Impaired glucose tolerance is frequently associated with insulin resistance syndrome. This is called syndrome X or metabolic syndrome. That consists of insulin resistance, but also compensatory hyperinsulinemia, obesity, dyslipidemia, and hypertension. So what are the diagnostic criteria for impaired glucose tolerance and diabetes mellitus? And in this table, you see impaired glucose tolerance, as was mentioned, it's a fasting glucose at the level of between 100 to 125 milligrams per deciliter. In diabetes mellitus, we have already symptoms, and in the bottom of these tables, you see that symptoms include polyuria, polydipsia, and unexplained weight loss with glucosuria and ketonuria. So in diabetes mellitus, we have these symptoms plus random or casual plasma glucose level more than 200 milligrams per deciliter. Or diagnostic criteria for impaired glucose tolerance can be results of the oral glucose tolerance test. I was mentioned that this test, sometimes these individuals only during this test have hyperglycemia. So if the individual, after consuming this, after ingestion of this solution of glucose, after 2 hours, the plasma glucose level is higher than 140 milligrams per deciliter, but less than 200, it means the individual has impaired glucose tolerance. But if the individual has fasting plasma glucose more than 126 milligrams per deciliter, or after 2 hours after ingestion of oral glucose is higher than 200 milligrams per deciliter, then it's diabetes mellitus. And one more diagnostic criteria is level of glycated hemoglobin more than 6.5%. So let's discuss more in details about type 1 diabetes mellitus. So it accounts for approximately 10% of all cases of diabetes. So nowadays it affects more than 3 million people in the United States and more than 15 million people in the world. But the prevalence of this disease is continuously increasing. And recent studies indicate that approximately 15,000 youths are diagnosed with type 1 diabetes every year. It accounts for most cases of diabetes in childhood, but not limited only to this group. So type 1 diabetes can occur in adult life. And in fact, 50% of individuals type 1 diabetes present as adults. The incidence is highly variable among different ethnic groups. So data from Western European diabetes centers show that the annual rate of increase of incidence is 5%, but in some Central and Eastern European countries is up to 9%. And speaking about gender, girls and boys are equally affected, but there is a modest female preponderance in some low-risk population. There is no correlation with socioeconomic status, and peak of presentation or peak of onset of this disease occur in two age groups. It's important to remember that at 5-7 years of age is first peak when the diabetes mellitus onset is, and at the time of puberty. So 5-7 years of age and puberty. So the first peak, 5-7 years of age, may correspond to increased exposure to infections with beginning in school and kindergarten. But the second peak corresponds to pubertal growth spurt induced by gonadal steroids and increased pubertal growth hormone secretions. That, in fact, is antagonizing effect of insulin. Also, there is a clear familiar clustering of type 1 diabetes. What this means? This means that if somebody in the family developed type 1 diabetes, so more members in this family in generations will develop this disease. So, prevalence in siblings, brothers, sisters of the patient is approaching to 6%. So, it may happen that few children may develop, but in general population, studies from United States show it's only 0.5%. So risk of diabetes also is increased when a parent has diabetes, and this may be different between two parents. So 3-4% risk is if the mother has diabetes, but 5-6% when the father has diabetes. So more risk for children is when father has diabetes. And it was proved that in monozygotic twins, or genetically identical twins, the rate of developing diabetes between them is 30-65%. In dizygotic twins, it's 6-10%. What environmental factors represent the risk for type 1 diabetes mellitus? First of all, viral infection. So different viruses have a role in pathogenesis type 1 diabetes, no one single virus, no one single pathogenic mechanism. What mechanism is direct infection of beta cells by the virus result in destroy of these cells and release of self-antigens. So the virus destroyed the infected beta cell, also formation of self-antigens. And this direct viral infection of antigen-presenting cells causing increased expression of cytokines and molecular mimicry exhibit homology to self-epitope. So virus include the mechanism of molecular mimicry, and the immune system continue to destroy these beta cells. So I was mentioned that congenital rubella is one of the approved viral infection that lead to diabetes. So you see that it leads to beta cell autoimmunity in 70%. So in congenital, so if a pregnant woman develop rubella, the fetus in up to 70% will develop autoimmune destroy of beta cells. So up to 40% of infected children will develop diabetes. And it can be even in 20 years. So when we take family history of a patient of type 1 diabetes, we may find that his mother 15 years ago had during pregnancy had the rubella infection. But of course the risk is higher if the fetus is also genetically predisposed, so has higher risk genotypes. Enteroviruses. Enteroviruses are other viruses that are associated with type 1 diabetes. Still it is under research. Mumps. You know that we vaccinate children against mumps, rubella, and measles, and this is not only to protect children against this infection that can be also dangerous, but also to decrease the spread of these infections in the population. What this means, if children will not develop this infection and will not transmit to other people, including adults, they will not transmit to pregnant women. So as a consequence, pregnant women will not get this infection during pregnancy, and fetus will not be affected. So moms lead to development, moms during the pregnancy lead to development of beta cell autoimmunity with high frequency pregnancy, or even in after in children can lead to autoimmunity with high frequency of type 1 diabetes in some cases. Hygiene hypothesis. So another hypothesis that is considered that environmental factors and contact with bacteria from environment may have protective role against some diseases. So this hypothesis is also including allergies. So hygiene hypothesis, in simple words, says that in industrialized countries, the incidence of allergy and autoimmune disorders is higher because children do not contact with environment, soil, water, and bacteria from this environment. So regarding to type 1 diabetes, is also considered that this is a disease of industrialized countries because there are because in industrialized countries there are fewer infections and the immune system is less well trained for its main tasks. The main task of immune system is host defense. So this theory is also called the microbial deprivation hypothesis, that meaning children living in the farm, in the village, is has a more trained immune system because this child contact from the beginning years of life with contact with the bacteria, environment. What do we have here? Okay, we have one more student. Bacteria, environment, and his immune system is more trained. And if the child is not exposed to childhood infection, then later in life, this individual has chances to develop autoimmune diseases, including type 1 diabetes. The diet. So breastfeeding, once again, yesterday I mentioned about breastfeeding, and already my colleagues also mentioned for you, probably you'll remember, breastfeeding is the most important nutrition for children, and this is a base for healthy life. Why? Because breastfeeding is proved scientifically that may lower the risk of type 1 diabetes, either directly or by delaying exposure to cow's milk protein. So early introduction of cow's milk protein and early exposure to gluten are considered to increase the risk of autoimmunity. Why? Because the gut is immature to meet other antigens than from breast milk. So what are these antigens? First of all, beta-lactoglobulin from cow milk, that is a major lipocaline protein in cow milk, and it's homologous to human protein glycodyline, PP14, that is a T-cell modulator. So what this means? That means that cow milk is foreign. It's foreign for the newborn and infant immune system, and that's why it increases by interaction of T-cell, it increases the risk of autoimmune diseases and allergy. Other dietary factors that play a role in diabetes risk, these are omega-3 fatty acids, vitamin D, ascorbic acid, zinc, and vitamin E. And vitamin D is a highly researched vitamin because it has a very various and very important biological role, and one role is not only in calcification of bones, mineralization of bones, but in role in immune regulation. And it is proved already scientifically that deficiency of vitamin D is more common in northern countries, and there are epidemiologic evidence that decreased levels of vitamin D in pregnancy, early childhood, associated with diabetes. Psychological stress, it's another environmental factor considered to increase the risk of diabetes, because studies show that many children develop type 1 diabetes after some stress. So mechanism, it's not known. It's considered that the stress may aggravate pre-existing autoimmune pathways or trigger autoimmunity through epigenetic mechanisms. So type 1 diabetes develop in a genetically susceptible host is developed by autoimmunity against the host beta cells. All these etiologic factors that was mentioned before may trigger this autoimmune response. And insulin deficiency that is caused by beta cell destruction lead to onset of clinical signs and symptoms of this disease. At the time of diagnosis, the patient may have some beta cells present, but they can produce insulin, and at the early stages, this insulin can be enough. So this leads to this partial remission of the disease, so-called honeymoon period. But over time, almost all beta cells are destroyed in type 1 diabetes, and the patient becomes totally dependent on exogenous insulin in order to survive. Excuse me one moment. So natural history involves following stages. I was mentioning 4 basic stages, but it's a little bit more. But logically, since the beginning of autoimmune reactions, first is preclinical autoimmunity, then onset of clinical signs and symptoms, transient remission, honeymoon period, and finally establishing disease and development of complications. In this table, you see that by age, in first stages, there is first environment can be involved genetic susceptibility, but when there is start progressive loss of insulin, patients develop symptoms. They may produce low concentration of C-peptide longer after onset, but later it decreases totally, and beta cells are destroyed completely. Autoimmune response is driven by different components of the immune system, and you see here how many lymphocytes and interleukin are involved in this autoimmune response against pancreatic beta cells. You see in this busy slide that the type and the stage of activation of antigen-presenting cells and also the cytokine environment dictate the differentiation of autoreactive T lymphocytes directed toward the beta cells. And this leads to differentiation of cytotoxic. Yesterday I mentioned about some subset of T lymphocytes that are cytotoxic, CD8 cells that attack pancreatic cells and lead to destruction of pancreatic islet. So insulin performs a critical role in the storage and retrieval of cellular fuel. Now, you know that its secretion is in response to feeding and is modulated by interplay of neural, hormonal, and substrate-related mechanisms to permit controlled deposition of ingested foodstuff as energy for immediate and future use. Insulin levels must be lowered to then mobilize stored energy during the fasted state. So in normal metabolism, there are regular swings between the postprandial high insulin anabolic state and the fasted low insulin catabolic state that affect liver, muscle, and adipose tissue. In this table, you see what is the influence of feeding with high insulin or fasting with low insulin on some metabolic processes in liver, muscle, and adipose tissue. And you see comparing is a comparison between postprandial state and fasted state. So in liver, you see that in postprandial state, there is glucose uptake, glycogen synthesis, absence of gluconeogenesis, lipogenesis, and absence of ketogenesis. But in fasted state, it's opposite: glucose production, glycogenolysis, gluconeogenesis, and ketogenesis. And in muscle, adipose tissue, also you may see for comparison. The lecture for preparing you may find on the website of the university. This lecture. So type 1 diabetes is a progressive low insulin catabolic state in which feeding does not reverse, but in fact exaggerates catabolic process. And with when insulinopenia or deficiency of insulin is moderate, glucose utilization by muscle and fat decreases and appear postprandial hyperglycemia. At even lower insulin levels, liver produces excessive glucose and begins fasting hyperglycemia. As a consequence, hyperglycemia produces an osmotic diuresis, glucosuria, when renal threshold is exceeding 180 milligrams per deciliter or 10 millimoles per liter. So as a result for the patient, there is a loss of calories, electrolytes, as well as a worsening of dehydration, and this leads to hypersecretion of stress hormones, epinephrine, cortisol, growth hormone, and glucagon. This contributes to further metabolic decompensation with impairing insulin secretion, antagonizing its action, and promoting glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. So the combination of insulin deficiency and elevation of plasma values of counter-regulatory hormones is responsible for accelerated lipolysis and impaired lipid synthesis, with increased concentration of total lipids in plasma, cholesterol, triglycerides, and free fatty acids. So the hormonal interplay of insulin deficiency and glucagon excess shunts the free fatty acids into ketone body formation. And the rate of formation of ketone bodies exceeds the capacity for peripheral utilization and renal excretion. And accumulation of these ketone bodies lead to development of this life-threatening condition called diabetic ketoacidosis. And compensatory rapid deep breathing because the patient has an attempt to excrete excess CO2, so-called Kussmaul respiration. So diabetic ketoacidosis is manifested clinically, first of all, with rapid deep breathing, Kussmaul respiration. Also, acetone that is formed by conversion of acetoacetate is responsible for fruity odor of the breath. So ketones, this ketone body, are excreted into urine and This increased loss of water and electrolytes and bicarbonate regenerating ability. So the patient developed this progressive dehydration, acidosis, hyperosmolarity, and diminished cerebral oxygen utilization. Consciousness becomes impaired, and the patient becomes no. Then somebody turn off the sound, please. Put it down off the microphone, please.
والله مش عارف انه مفتوح.
Don't interrupt Nidal.
Okay, doctor. I not know.
Nidal, stop interrupting, please.
Okay.
Yahoo!
Doctor, we miss you.
Nidal, turn off the microphone.
Okay.
Yahoo!
Clinical manifestations. So, as you understand, the decrease of beta cell mass with worsening insulinopenia, progressive hyperglycemia, and ketoacidosis will all imply that symptoms steadily increase, and from polyuria to DKA, diabetic ketoacidosis, and coma. This may happen in several weeks. So it's a quick process. So deterioration of clinical condition is a quick process, and initially only when only insulin reserve is limited, then occasional postprandial hyperglycemia occurs. But if insulin reserve is diminished progressively, clinical condition worsen rapidly. So with further beta cell loss, chronic hyperglycemia causes more persistent diuresis with nocturnal enuresis and polydipsia. Patients also have loss of calories. That's why they have hyperphagia, increased appetite. And if this hyperphagia does not keep pace with the glucosuria, loss of body fat start with clinical weight loss. So an average, a healthy 10-year-old child consumes about 50% of 2,000 daily calories as carbohydrates. When the child becomes diabetic, daily losses of water and glucose may be at about 5 liters and 250 grams that represent 1,000 calories or 50% of the average daily calorie intake. So you see that a diabetic child loses everything that he consumes. So even if the child has this compensatory increase in intake of food, the body starves because of unused calories lost in the urine. When extremely low insulin levels are reached, ketoacids accumulates, and the child deteriorates with Kussmaul breathing and coma. Ketoacidosis exacerbate fruity Kussmaul breathing, fruity breath odor, prolonged corrected QT interval on ECG, and diminished neurocognitive function, coma. So about 20 to 40% of children with new onset diabetes progress to diabetic ketoacidosis before diagnosis. So in young children, this process happens much more quickly over a few weeks. That's why you see that in about 1/3 of cases, children with diabetes are diagnosed at the point when they develop ketoacidosis. In infants, most of the weight loss is acute water loss because they will not have had prolonged urinary loss of calories from glucosuria, and there will be an increased incidence also of diabetic ketoacidosis. In adolescents, the course is usually more prolonged. It can take few months till they develop DKA, and most of the weight loss is fat loss. But before diagnosis, they may have also water loss from dehydration. So any stressful environmental conditions, illnesses, viral illnesses, or any respiratory viral illness or some other stressful events will hurry up this process of clinical worsening. So point of diagnosis, so the most important is that if the child has inappropriate polyuria, childhood dehydration, poor weight gain, or conditions like the flu, we have to suspect diabetes. And we have to check serum glucose level. So because we very quickly laboratory can determine hyperglycemia, glucosuria, or dipstick in the urine, and ketonuria also. So non-fasting blood glucose level greater than 200 milligrams per deciliter it's a typical symptom of diabetes. It can be with or without ketonuria. If the child is obese, we must think about type 2 diabetes mellitus. So if we confirm the hyperglycemia, we have to be very careful if decay is present, because we have to check electrolyte abnormalities, even if there are no evident dehydration or deterioration of neurological state of the patient, because in a few weeks he may worsen very severely. And the important diagnostic method is baseline hemoglobin, glycated hemoglobin, type A1C, that is confirmatory. And it helps us to estimate the duration of hyperglycemia and provides initial value by which to compare the effectiveness of subsequent therapy. Falsely low levels of glycated hemoglobin can be seen in hemolytic anemias, pure redoplasia, blood transfusion, and anemias associated with hemorrhage, cirrhosis, renal diseases that treated with erythropoietin. So these factors should be considered in order not to misdiagnose the diabetes. Also should be considered the fact that about up to 30% of patients with type 1 diabetes may have elevated thyroid stimulating hormone and anti-thyroid antibodies. Also about 10% may have signs of celiac disease. Because genetically they are close, these diseases, and they may have common pathogenetic pathways. So DKA is the end result of metabolic abnormalities, and it occurs once again in 20 to 40% of children new onset diabetes who do not successfully manage their illnesses. So the risk factors for diabetic ketoacidosis, this is a young age, poor diabetes control, missed insulin injections or insulin pump failure, infections, stress, a low socioeconomic status, and even psychiatric disorders. This is a difference between hyper and hyperglycemia we discussed about. But about ketosis, some features already was discussed. Important is to mention that in ketoacidosis, blood ketone concentration, we have not only ketonuria, but also blood ketone concentration is increased between up to 7 millimoles per liter. And in ketoacidosis, the level of ketone bodies in the blood is higher than 7 millimoles per liter, and pH is 7.3 or lower. So acidosis by definition is acidemia when pH of the blood is below 7.35. And it is manifested by this Kussmaul respiration, confusion, lethargy, and abdominal pain. So the mandatory blood tests include arterial or venous blood gases and electrolytes, sodium, potassium, chloride, bicarbonate, and total CO2 content. So DK8 is a complex metabolic condition that include hyperglycemia, ketosis, and acidosis. Once again, for you to remember, symptoms, this is a deep rapid breathing, fruity breath odor, very dry mouth, nausea, vomiting, and lethargy, drowsiness. It needs emergency treatment and emergency evaluation. So hyperglycemia, you remember, it's more than 200 milligrams per deciliter. Ketosis, it's a ketone bodies presented in blood and urine. And acidosis is pH less than 7.3 or bicarbonate less than 15 millimoles per liter. So DKA is categorized by the severity of the acidosis. It can have mild, moderate, and severe evolution depending on pH of the blood and bicarbonate concentration. In severe, pH is less than 7.1 and bicarbonate concentration less than 5 millimoles per liter. Here in this table, you see diagnostic criteria for diabetic ketoacidosis and hyperosmolar hyperglycemic state. That's why, once again, it's important that thorough history is imperative. That it means very important. So, for a new onset diabetes, a recent history of polyuria, polydipsia, polyphagia, weight loss, a family history of diabetes, and symptoms such as headache, blurry vision, nausea, vomiting, abdominal pain, difficulty in breathing, changes in behavior, and even concurrent illness or infection are signs that has to lead to diagnosis of diabetes. In patients with pre-existing diabetes, that means he was already diagnosed with diabetes, but if the patient has some symptoms, we have to ask when was the last meal or carbohydrate intake, what is the current and routine blood glucose level, when was the last insulin dose, what type of insulin and what was the route of administration. We have to ask about past hospitalization history, duration of symptoms, and precipitating factors of symptoms. So when the patient develops symptoms such as physical effort, changing in eating habits or diet, stress, missed insulin doses, or intercurrent illnesses. So these points are mandatory points and aspects of patient history, of diabetic patient history. On a physical assessment, we have to assess for dehydration. So we assess for vital signs, mucous membranes, capillary refill time, skin. We have to assess for acidosis. So we have to check if there is present fruity breath odor, deep rapid breathing, Kussmaul respiration, and assess mental status using Glasgow Coma Scale, but pediatric Glasgow Coma Scale or AVPO. And we have to, that is a rapid assessment of level of consciousness. And we have to assess for signs and symptoms of possible infection. So primary assessment, of course, first is ABC. ABC, airway, breathing, and circulation. Then patient should be evaluated clinically, vital signs, weight, mandatory is weight of the body, and the patient with diabetes is weighted every day. We have to assess clinical severity of dehydration, neurological status, and the patient must be monitored cardiocirculatory. Laboratory include initial laboratory blood glucose, urine ketones, venous blood gases, basic blood chemistry, and additionally CBC, osmolarity, glycated hemoglobin, pancreatic antibodies if available, and additional testing if necessary, like X-ray, CT, cultures. Another diagnostic evaluation that is routine monitoring for patients with diabetes is blood glucose testing. So the blood glucose test measures the amount of glucose in the blood. It is for screening and monitor treatment, and normal, you remember, is between 80 to 120 milligrams per deciliter. Ketone testing is simple to do with a dipstick in the urine, and you see that it changed the color. So you see in the left side when there is no ketone in the urine, negative, and it becomes very dark when it's a high amount of ketone body in the urine. So if we find more than 1.5 millimoles per liter in the urine, the child is at risk for developing diabetic ketoacidosis. Blood gases are adequate to determine blood pH and can be used arterial blood sample or venous blood sample. And we have to look at the pH, the amount of oxygen, CO2, and bicarbonate. So metabolic acidosis is defined as low pH and decreased bicarbonate. Metabolic alkalosis, just for you to recall, is high pH and increased bicarbonate. So in patients with diabetic ketoacidosis, we find metabolic acidosis. The treatment for DKA, that is the most severe manifestation, clinical manifestation of diabetes type 1, is first of all transfer, if necessary, to higher level of care, prevention of serious complication, and the most serious complication in diabetic ketoacidosis is cerebral edema. And rehydration. Rehydration is intravenously. First, in two phases. In first phase, we introduce volume expansion, volume expander, we normal saline we transfuse, and in second phase, we replace fluid deficit and maintain fluids. Also, treatment include insulin administrations. It can be continuous intravenously or subcutaneous intramuscularly. We have to replace electrolytes and reassessment and ongoing monitoring is mandatory. Just for you to have a picture, for IV fluid, we determine hydration status, and depending on if it's mild to moderate dehydration, we administer normal saline. That means 0.9% in a dose about 10 milliliters per kilogram per hour, or double dose if it's a hypovolemic shock. Children with DKA will have fluid deficit in about 5 to 10%. Shock is rare in pediatric DKA, but replace the fluid deficit should be replaced within 48 hours. So the staff of intensive care units have these 48 hours to replace these electrolyte disturbances. Cerebral edema is the most severe complications of DKA. It is less than 1%. It occurs in less than 1% of pediatric DKA episodes, but children who develop cerebral edema in 60 to 90% will die. So even if it's not frequent, but it's associated with high mortality. And the problem is that the rest of children of survivors that will survive cerebral edema will have permanent neurological injury. Symptoms of cerebral edema in diabetic ketoacidosis include headache, drowsiness, and the problem is that many children may be asymptomatic until the neurologic condition deteriorate severely. Risk factors for cerebral edema include small age, less than 5 years, new onset diabetes, high glucose level, severe dehydration, acidosis, and treatment with bicarbonate. So warning signs, this is altered mental status, age-inappropriate incontinence, can be also vomiting, headache, lethargy, high blood pressure, and age. Treatment include raising the headbed to at least 30 degree of angle and mannitol. Mannitol intravenously so the mainstay treatment is infusion with mannitol. Also should be avoided aggressive hyperventilation, and treatment should not be delayed. About the diabetic ketoacidosis was mentioned already. That therapy is hydration and correction of pH, correction of electrolyte disturbances. Generally, treatment for type 1 diabetes involve many goals. First of all is to maintain a balance between glucose control and to avoid hypoglycemia. Also, another aim of the treatment, the goal is to eliminate polyuria and nocturia, to prevent ketoacidosis, and to permit normal growth and development of the child with a minimal effect on lifestyle. So, of course, patients with type 1 diabetes will receive insulin. In adolescent children, the dose is higher, and the insulin optimal dose is determined empirically with a frequent self-monitoring of glucose level in children. Starting dose of insulin is depend on the age and depend on ketoacidosis. You see in this table, if there is no ketoacidosis in prepubertal age is about 0.25 to 0.5 units per kilogram daily. Of course, there are guidelines and protocols for this treatment. Insulin treatment has many details that you can read through opening the textbook or even this lecture that is basically based on Nelson textbook of pediatrics latest version. And we have to remember that this patient who received insulin need a special diet and should monitor frequently the blood glucose level. Nowadays, very good is for children that there is an insulin pump. And insulin pump therapy, it's a continuous subcutaneous insulin infusion through battery-powered pumps that provides a closer approximation of normal plasma insulin profiles and increased flexibility regarding timing of meals and snacks compared with conventional insulin injections. The good thing, very good thing, is that these pumps can be programmed with the patient's personal insulin dose algorithms, and the patient can enter the pump. The patient can introduce information about the meal and about the insulin, and the pump computer will calculate the proper insulin bolus dose. Also, another devices that are used for patients with diabetes, these are devices for continuous glucose monitoring. So these devices do not directly control insulin administration, but provide glucose readings, and these allow better control of insulin administration by patient and families. And also there are some sensor sound alarm to avoid hypoglycemia, These patients also receive nutritional guidelines with a specific distribution of carbohydrates, fiber, proteins, fats, cholesterol and sodium, depending on percent of calories, and with recommendation of daily intake. Every 3 months, the diet is reevaluated. So these patients are counseled at a specific center, at a specialized centers, until they get a stable evolution of the disease. If we speak about adolescents, it's important alcohol consumption in high school, so they are trained about safety regarding alcohol consumption, and about snacks. Of course, they vary according to individual needs. Alternative sweeteners are suggested for these patients, and different educational techniques, because these patients should be educated, because it's a lifelong regimen. Patients with eating disorders should also need additional psychological counseling. And exercises, if the children, of course, growing need exercise, they are also educated regarding the hypoglycemia and how to prevent ketosis. So monitoring is necessary, absolutely vital for these patients. Monitoring is can be by devices that I showed you, this continuous monitoring system, or can be monitored, like in this picture, daily by small spring-loaded devices that automates capillary bloodletting in a relatively painless fashion. So parents and patients are taught to use these devices and to measure blood glucose at least 4 times daily at the initial steps of treatment. So they have to measure before breakfast, lunch, supper, and bedtime. When insulin therapy is initiated, they may affect the overnight glucose levels. That's why self-monitoring should also be performed at midnight and 3 a.m. to detect nocturnal hypoglycemia. So ideally, the glucose concentration should range from 80 to 140 milligrams after meals. And depending on so you see in this table that depending on the age, there are targeted blood glucose levels. So complications are divided into 3 major categories: micro, macrovascular, and neuropathies. And there are specific screening guidelines for these complications. So, and it's these patients are educated when to do specific examinations at ophthalmologists, spot urine samples for and creatinine ratio for nephropathy, and physical examination in neurologist, to do angiography, ophthalmoscopy, in order to detect in time complications. Also, these patients should monitor blood pressure, thyroid gland function, and transglutaminase antibodies. So this was most of the information that I wanted to present for you today. And if you have any questions, please feel free to ask. Okay. Looking for questions. Any questions? Okay, thank you for attention. And tomorrow about lectures. Tomorrow I think no. Tomorrow I think no, but today for sure you have a lecture on epilepsy. Mm, yes. Probably no, it's not done for today. Let me ask my colleague. No, it's today. I asked my colleague at what hour he start. One moment.